Hello viewers, today I am again back, but this time with a definitely an interesting case, but I have a message after this presentation that you have to see the child as a whole. Don't go into the uncommon presentations, but see the child, then you will pick up the diagnosis. That is why I thought I will shoot this video today along with my pathologist who is with me. This was a 3.5 months old baby who was brought with respiratory distress and cough for 2 days, and with those complaints the child had gone to the OPD. There one of my senior residents had seen the child, and having seen the child was in distress, child was having cough, so a possibility of bronchiolitis was kept. The negative history was asked for. There was no history of any rest suck cycles. There was no history of any constipation or diarrhea. So keeping all those things in mind, there was no history because of the distress, there was no history of any seizures. So child was referred to the emergency to another senior resident who is posted in the emergency as a case of an acute bronchiolitis. And rightly so, it's a 3 months old baby, short history of cough and respiratory distress for about 2 days. Now this child came to the emergency, and one of my senior residents again saw this child. This child was a product of a normal vaginal delivery. Birth weight of the child was 2.7 kg. There was all, before 3 months, everything was uneventful. Child was being breastfed and was thriving well. So when the child was examined, first of all the general physical examination was done, and general physical examination, as I said, was thriving well, so there was no failure to thrive. Child was quite okay, and there was no evidence of any skin lesions or anything like that, no dehydration. The child was examined, chest examination, because the child was in distress, and GP examination revealed that the child had a respiratory rate of about 64, and the child had severe subcostal recession. The child was further examined. It was a tachycardia was noticed by my senior resident. It was about 180. The pulses were all well palpable, but tachycardia was there, tachypnea was there with the recession. So dyspnea was already there. Now, as anybody, you people would straight away go on to the respiratory system examination. When the respiratory system examination was done, this child had got bilateral bronchi and had got basal crepitations. Examination revealed that the child has got a liver of about 4 centimeters. But when the senior resident was examining, that is how I know that he called me. There was a big kind of a mass which was palpable, and that mass was in the left lumbar area, coming onto the iliac fossa, and it was crossing the midline also. So this kind of a mass, which was missed earlier by the senior resident in the OPD. I agree that OPD is very heavy, but my message, as I said at the outset, you always have to see the child as a whole. Then when the child was examined, and when I also saw the child was thought to be in congestive heart failure. Why? Because this child has the huge liver, respiratory distress and tachycardia.
हाँ ये देखो, इसको देखो, ये है, दिस इज ए बिग मास हियर एंड इट इज ए लॉब्यूलेटेड सा मास. इसको फोकस करिए, ये देखिए, इट इज ए लॉब्यूलेटेड मास ऑन दी एक्सटेंडिंग फ्रॉम दी लेफ्ट लंबर है, नीचे जा रहा है, आइलियक एरिया में जा रहा है. इट इज नॉट क्रॉसिंग द मिड लाइन. So see this. Now this child has got also hepatomegaly, which is about 4 centimeters below the costal margin. Tachycardia, tachypnea. So this child is in congestive cardiac failure, along with a mass here, which is a lobulated mass. So this could be a case of a young child, could be a case of a neuroblastoma with paraneoplastic syndrome presenting as DCMP. Okay. So
in the emergency we got the CBC done. CBC will report come later, but luckily we have a cardiologist with us, and we have we could get the echo done. at the bedside. That is a very good facility which we have got here at Baba Saheb Ambedkar. And when the echo was done here, it was revealed that this child has got, I'll just read out the echo findings. Now first of all, echo was revealing the RV-LV was dilated, there was global hypokinesia. The left ventricular ejection fraction was only 10 to 15%, 15-20%, but there was no other cardiac abnormality. Now having said that, this was surprisingly, you have got a mass, you have got a dilated cardiomyopathy. Now certain things in the history which we had not taken earlier, if you have got a mass, I ask a question to Vanya, that if you have got a mass in a 3-month-old baby, आप उस तरफ दिखाइए उनको, तो a 3-month-old baby, what possibilities would you like to keep in this child?
So first thing we'll see if that was a spleen. Could that mass is splenomegaly तो नहीं था
थोड़ा
सर.
जोर से बोलो.
Splenomegaly.
Splenomegaly.
Yeah.
नहीं, ये तो hard mass था ना, ये firm to hard mass was noticed in the left lumbar area and it was going into the iliac fossa. So it cannot be in the lumbar area going on to the iliac fossa. So it cannot be a spleen. So my question was, a 3-month-old baby coming and you are finding a firm to hard mass at that area. So my question to you is that whenever you get a child like this, what possibilities you will like to keep in mind? Not the spleen.
So renal mass.
Yes, very good. Renal mass. So a 3-month-old baby has got a renal mass, suspected clinically renal mass. What would you like to keep in mind?
So congenital Wilms tumor.
Very good. So you can have a possibility of a congenital Wilms tumor. One is that. Anything else? Harshi is raising his hand. Would you like to say anything?
Sir, my guess is either any mass and either Wilms tumor, or we can suspect some CHPS, congenital hypertrophic pyloric stenosis.
Congenital hypertrophic pyloric stenosis will not go into the left lumbar area.
Yes, then
it will be in the epigastrium. You may feel a lump, and the history will be not like this child had a respiratory distress. This child will never had any history of any regurgitation or vomiting, and child not thriving well. So I don't think that could be the possibility of a hypertrophic pyloric stenosis. Anybody else? Shashma, you would like to say anything? आप इनको माइक्रोफोन दीजिए.
Sir, I would like to keep congenital mesoblastic nephroma first DD. I would like to keep congenital mesoblastic nephroma
Very
first
good.
DD. Then neuroblastoma, congenital Wilms tumor, malignant rhabdoid tumor,
Very
or
good. So important thing which he rightly said was that not only Wilms tumor, you always have to keep in mind a neuroblastoma. Neuroblastoma appears little early. You have an infantile variety or a congenital neuroblastoma which presents much earlier. And she rightly said the commonest of the tumor, which is a benign tumor, is the congenital mesoblastic nephroma. So these are the few DDs I would say clinically. Now my question is to you people is, why I am presenting these cases. This child has got two things. By echo we have already found out that this child has got cardiomyopathy, and now the child has got neuroblastoma which we are suspecting. Then what we went ahead and we sent this child was very sick. So we got on bed the X-ray also, got it done. I will show you the X-ray. X-ray is also revealing a cardiomegaly. You can focus X-ray. This is showing a cardiomegaly very clearly. So you have a cardiomegaly proven by your echo that it has got a dilated cardiomyopathy. Now my question is, what I want to highlight here is that you have to keep everything together. Now you have these two things. What will you like to keep in mind? A 3-month-old baby. We went ahead straight away went for the ultrasonography. Now I'll read about the ultrasonography. Liver architecture is normal, ecotexture is normal, right kidney is normal, left kidney there is mild hydronephrosis. This could be because of the compression of the on the kidney or the pelvis because of the mass. There is a mass of the size of 9 into 9 into 7 centimeters with peripheral vascularity, predominantly hyperechoic with areas of necrosis and calcification. So it's very important. So if you have an area, why I want to highlight here is, if you have a mass with areas of necrosis and calcification, the neuroblastoma comes much higher. Usually you don't see calcification in a patient of Wilms tumor. So that is one thing you must keep in mind. So ultrasonography also was trying to support us, but still I could not solve, I also didn't know frankly, that why there is cardiomyopathy in this child. Now if I ask Dr. Archana has entered late, I asked Dr. Archana, what could be the causes of cardiomyopathy in a small child who is just 3 months of age? Grossly, broadly.
So basically, any viral infection itself can cause cardiomyopathy, and though there are very rare cases of dilated cardiomyopathy associated with neuroblastoma also over there when we searched out back retrospectively.
We did search it. Before search, the possibility you rightly said is it is a post-myocarditis cardiomyopathy. When I was reading the literature, one important thing which I was asking Neeraj also, that I have few register also sitting here, can you tell me any cause of cardiomyopathy which is reversible and quite commonly it may be there in a child. Cardiomyopathy in a 3-month-old baby, I have seen only one child till date. And that I was just reading the literature and there are 1 or 2 case reports. Why I am mentioning here is because calcium deficiency, hypocalcemia can also cause cardiomyopathy, which we don't recognize very much. Because calcium deficiency, vitamin D deficiency is pretty prominent in the Indian setup. But if your mind knows, then only eyes would see. And then in the child with hypocalcemia, sometimes I only saw, as I said, one child. There if you give calcium, you give vitamin D, the children improve, the cardiomyopathy improves. Now post-myocarditis cardiomyopathy is not going to improve, it's irreversible. But here it is a reversible cause which you must appreciate because you are all pediatricians. Everybody should know that hypocalcemia can also lead on to the. So what are the other causes of dilated cardiomyopathy, as Dr. Archana rightly mentioned? I didn't know it, we looked into the literature, and then this child, there was something called as catecholamine induced. This is called paraneoplastic syndrome. What is a paraneoplastic syndrome is that you have a neoplasm, it secretes some hormones, it secretes some peptides, and because of the immunity or immune response, there are certain changes which occur, which are this paraneoplastic syndrome are very common, especially with the neuroblastoma. How the child may present you with sweating, child may present you with obstipation, diarrhea, constipation, so all those things can occur. You can have a Horner syndrome, you can have lot of other things in a tumor, and that too is common with the neuroblastoma. So you must, sometimes short note comes, paraneoplastic syndromes. So you must know what is a paraneoplastic. Now having said that, we also sent this serum calcium level for this child, and the serum calcium level was about 9 milligram. So this hypocalcemia was not there in this child. Usually it occurs in a child if the mother is deficient and the mother is breastfeeding the baby, then the child may be born with hypocalcemia. So this you must keep in mind. Common things always come. Okay. Now having said that, now you have DCMP. Why it is occurring, I have told you, it is because basically catecholamine induced, and this child had very tachycardia, so much so that this child had heart rate of about 180. So then we did the FNAC, and now I hand over my mic to Dr. Nidhi. She is the pathologist with us, and she will talk about that what are the cytological findings which we got when we had done the FNAC. Dr. Nidhi, please.
Thank you, sir, for the opportunity. So we received around 5-6 smears, air-dried smears done as an FNAC, blind FNAC from this mass. And the smears were very cellular, as we can see in this photomicrograph. The smears were markedly cellular. We had sheets of these medium to large size cells which had high NC ratio, scanned cytoplasm, and the nucleus was large, round to ovoid, and it had an opened up chromatin. So this is largely showing the the cellularity of the smear. We have another high power view of the same. This high power view shows these highly atypical cells, and we could appreciate that there was this nice rosetoid pattern, an acinar and a rosetoid pattern which was present of these tumor cells. And in the background there were foci of necrosis, and also this pink fibrillary material was appreciated. There was no calcification per se, but then in view of the high cellularity of the tumor, the round cell appearance, so the differential in the mind, we were sure that this was a malignant small round cell tumor, and because of the site and the pediatric age group, there was a long list of differentials in mind, as we all know. So we've got to rule out in the pediatric age group within abdominal cavity site, we've got to rule out an extraskeletal Ewing spinnet, a lymphoma, neuroblastoma, extra monophasic Wilms tumor. We have to keep a desmoplastic small round cell tumor also in the differential. So there was a wide list of differentials, even a pancreatoblastoma, considering this is a retroperitoneal site. So even that should be kept in mind. Because this is the left side of the abdomen, we did not keep a hepatoblastoma in the differentials, but yes, there is a whole lot of list of malignant small round cell tumors that should be kept in mind. And in this scenario, considering the age, considering the ultrasound findings, considering the cytological features, because of the presence of neuropil in the background, the possibility of neuroblastoma was kept way high. And we expected that we could get a cell block from this patient or a true cut biopsy. And the final diagnosis can only be made after doing a immunohistochemistry on a true cut or a immunocytochemistry on a cell block, which would encompass a panel of antibodies, immunoantibodies, as we all know. So we would do a CD45 to rule out a lymphoma, a CD99, maybe a fly one for ruling out an extraskeletal Ewing spinnet, and we would want to do chromogranin, synaptophysin, NSC, which when positive would favor the diagnosis of neuroblastoma. Even a rhabdomyosarcoma is a very important differential in this case, which can be ruled out by doing a myo-D1 or a myogenin, which would be positive in that case. So, considering the elaborate correlation, we boiled down to a differential diagnosis of neuroblastoma as a first differential, followed by monophasic Wilms tumor, for which we could have done a WT1. So.
Thank you, madam. The question is, you got a very good lecture, no? You are pediatricians. You must understand what is IHC, what are the various markers. Nowadays they ask in the exam. But yes, three things you have to keep in mind. What is the clinical diagnosis? How you can confirm it? Somebody can ask me, this child actually did not give us much time. This child was so sick that this child succumbed within few hours. And I am very happy to say that we could get all these things done in few hours, because otherwise I would have gone ahead and I would have gone for the biopsy, or I would have gone for the ISC, because I could only do the FNAC. Otherwise I would have taken a biopsy and I would have sent it for the ISC. So I think this child did not give us much time, and the child succumbed. But yes, this child was then put on the measures for the congestive cardiac failure. The child did not improve and child passed away. But then the message which I want to give at the last is, don't take the diagnosis piecemeal. You sit in the OPD, I understand it's a heavy OPD, but you have to see the child as a whole. You don't see the child as a whole. You only see the respiratory distress, cough for 2 days, keep a diagnosis of bronchiolitis. Kindly see your CVS, kindly see the abdomen, look for the liver size, look for the spleen. So if you see all those systems together in this limited time frame, you may not be able to miss the diagnosis. I am also a little surprised here. Somebody can ask me, this child, usually these kind of tumors are picked up by the mother only. While bathing, the mother may say that the child has got, and they may come with that mass. And I was very surprised when I asked the mother, she was not knowing anything about that there is some mass. So finally in the end, try to put everything together and come out with one diagnosis. As in this child, I wanted to highlight only this part, right? So you have to keep in mind what are the differential diagnosis of round cell tumor, what is the differential diagnosis of dilated cardiomyopathy in a small child, and then you have to keep those things, what is the differential diagnosis, clinical differential diagnosis, right? So that's all. Thank you very much. Thank you.
Thank you so much.